Thank you very much for that introduction. It's a real pleasure to be here today to speak to you a little bit about this maybe new topic to many of you. It's such a distinguished panelist of speakers that have been here today, and I really feel honored to be a part of that. Thanks also to Dr. Hallett for inviting me. So after that lecture, it's a little hard to consider something more invasive, but I guess we will actually do that. My pictures aren't quite as graphic, so but I also have some videos, so hopefully as the last speaker today I can keep your attention. So a little bit about what is deep brain stimulation therapy. Maybe some of you here actually don't even know about this. It's an implantable system that can modulate brain activity to improve symptoms. It's kind of like a brain pacemaker, you can think of it that way. And it has various components. Guessing this is us. It has a lead that goes up into the brain that's connected to an extension wire that then attaches to a neurostimulator, also known as an implantable pulse generator. This is a picture of it looking a little up close. And there's also a physician programmer that comes with the device for physicians to adjust the device, and then patients have their own little controller that can turn on and off the device. And the entire system is under the skin, so you don't see any of these parts. And of course, this requires a neurosurgical procedure to place, and it's performed using a stereotactic approach, which means we get the slides back, which involves placing patients generally into a stereotactic head frame that then allows physicians to know exactly where the lead will go into the brain. Hopefully it will show up again. So all patients before having this procedure undergo an MRI of the brain, and the neurosurgeon can then identify the location that they'd like the lead to go, and they can use the stereotactic technology to make sure that the lead goes into the exact place in the brain. While they're doing this procedure, they can also record the neuronal activity of the cells as they're introducing a recording electrode. And different cells in the brain have different firing frequencies and sound a little different. So they can also use this microelectrode recording information to help with knowing where they are exactly in the brain. Any idea what's happening? It just stopped working? Is there a picture on the screen? Do you want to just try to wiggle the connection before that helped? Maybe, yeah. Yeah, it also is on a thumb drive. Okay, great. We're back, it looks like. Thank you. Okay. So this was the picture I was going to show that shows the stereotactic head frame, and two small little burr holes are made in the skull and about the size of a quarter, and the electrode can be placed through that area. This is a schematic down here at the bottom. I don't know if you can see this well, but this is an actual recording of the neuron as it's being recorded while the electrode is being placed, so that you can verify where you are by the signature of that individual neuron. Now, there are lots of different places you could think about putting an electrode in the brain and stimulating to try to modify movements. The basal ganglia is an obvious choice, and it's what is used. There are this technology is used for patients with Parkinson's disease, as well as patients with essential tremor. So for patients with essential tremor, typically the thalamus is the target choice. In patients with Parkinson's disease, we use the subthalamic or the globus pallidus interna as the targets. And generally in patients with dystonia, as I'll talk about next, the target that has been traditionally used is the globus pallidus. So the system has some components that are helpful to understand. On the end of the brain lead, there are actually 4 little tiny contacts, And the electricity, the stimulation, can be delivered through any one of these different contacts or multiple contacts in combination. And then you can also vary various parameters. You can vary the amplitude of the stimulation or the intensity. You can adjust the pulse width or the duration of the stimulation, and you can also adjust the rate. And by adjusting these different variables, you can have a different clinical effect on the patient's symptoms. So what about dystonia and using DBS? It's indicated actually for unilateral or bilateral stimulation of the globus pallidus or the subthalamic nucleus to manage chronic, intractable, drug-refractory, we heard about that, primary dystonia in patients who are 7 years of age or above. And this is going to include patients that have generalized dystonia, segmental dystonia, hemidystonia, and also cervical dystonia. And how you define segmental dystonia, we've talked about that today, but in my mind also cranial and cervical dystonia together would qualify as a segmental dystonia. So there has been quite a bit of work now using DBS to treat dystonia. For the last 10 years this has been performed, and as I mentioned, traditionally the lead has been placed within this globus pallidus region of the brain. And there are now published reports on about 250 patients when I reviewed this about a year ago. And most series report about a 40 to 70% improvement. And now we have actually some really good class 1 evidence of 2 randomized double-blind control studies in patients with generalized and segmental dystonia improving with GPI-DBS. And this is a patient of mine. You can tap the videos there. That has a little boy who had generalized dystonia for about 9 months, continued to get worse. And I show this video because maybe some of you haven't seen a lot of patients with generalized dystonia, but this is where the technology and the idea that maybe we could use DBS for dystonia for other forms of dystonia has come out of, because it's been a very effective therapy for patients with generalized dystonia. So here he is really having difficulty controlling his arms, his legs, his speech. He's got difficulty he has some blepharospasm as well. And then 1 week after surgery, just a remarkable improvement, able to go back to school and is walking again now. So very dramatic improvement with this kind of therapy. So what about patients with cervical dystonia? There have been more efforts now to see if this can be helpful for this patient population as well. And if you look at the literature, there's been very little data on DBS for focal dystonias, and most of the literature has been in patients with cervical dystonia. So about 53 cases now have been published in the literature, and again, this is not real randomized trials usually. It's small case series or anecdotal case reports. But the outcome is promising, somewhat variable between 43 and 76%, but most patients are showing good long-term benefit from the surgery. And here's a case of ours, a patient who had idiopathic cervical dystonia. You can click those videos again, please. Here on the left is her exam before surgery. Hopefully videos will play. With a pretty prominent right lateral callus, lots of neck pain. And then here on the right is her exam. The video is not playing very quickly, but her neck position is much better. I think anybody could tell that she's better. Okay. It's not letting me advance the slide now? Okay. Uh-oh. So it looks like the PowerPoint things crashed. So maybe you can reload that. Having lots of challenges here. So I'll go on to the next part of the talk was going to be about, so now that I've showed you some examples of cervical dystonia, what about blepharospasm and dystonia? And that's what we're all here to talk about today. So there's really been no published cases so far that I could find on pure blepharospasm, patients with only blepharospasm undergoing DBS. But there are some studies now to suggest that patients who've undergone cranial dystonia, or who have cranial dystonia, undergoing DBS. And so we have some data to show you that, when the slides come back, about this kind of work we've been doing. Okay, quickly go ahead here. So a few years ago now, we published our pilot study where we used GPI-DBS to treat patients with cranial cervical dystonia, or MAGE syndrome. And we were able to show a pretty dramatic improvement in symptoms. Now, these were patients who had failed oral therapies, which, as many of you had just heard, oftentimes are ineffective. And there were also patients who had failed botulinum toxin therapy, so very refractory patients who also had a lot of disability, were thought to be medically in good shape for this type of procedure, and were very well informed that this may or may not work. So this was some data from the first 6 patients. And as many of you now may be familiar with the outcome scales for dystonia that we use, the Burke-Von-Morrison scale is a rating scale we use to look at generalized dystonia outcomes. And then the Toronto Western Spasmodic Torticollis rating scale, which looks at cervical dystonia outcomes. And really, across all measures of these individual subscales, we saw improvements. And so specifically for Blepharospasm in this patient group, we did see a statistical difference in improvement in the Blepharospasm rating as well. So let's hope the video doesn't crash. Okay. So this is a patient on the left who has Blepharospasm as well as a little bit of cervical dystonia, which wasn't apparent on this video segment as much, who had GPI-DBS, and then his results are on the right. So has had a pretty remarkable, and now I just saw him a few weeks ago, 3 years out, still having good benefit from this procedure. Okay, we can go on to the next one. This is another patient who we also took care of many years ago now. It was actually our first patient with cranial cervical dystonia we treated with GPI-DBS. And almost as soon as we turned on the stimulator, there was improvement in his Blepharospasm as well as his oral mandibular dystonia and cervical dystonia, which has persisted now for 3.5 years. Go to the next one. So we were excited by this and continued to offer this to patients we thought were appropriate candidates. And after our first 14 patients were implanted, we started to notice that patients were coming to clinic and saying, I'm having a little more trouble now with my arm, for example, having more difficulty writing, I'm having a little bit more difficulty getting up from a chair, I can't walk as well, subtle slowness movements. And so we surveyed them. And we found that, this is probably a difficult slide to read, but it was extremely common in this patient population who had previously not had any problems with their arms or legs. Their dystonia was only in their face and their neck. Were developing difficulties with doing different motor tasks in their arms and legs. So we have tried extensively, obviously, to adjust the DBS programming settings, as I mentioned, could be adjusted. But it's not been possible to completely eliminate this side effect from the stimulation without causing the dystonia to be less well controlled. So we felt this was a limiting factor in how much better we could make people. And we started to think about, is there another option? Is there another brain target we could look at in the brain to potentially stimulate that would not give us this side effect potentially? And this is a little video segment of the patient before. We'll see if it will run. You can try it. And yeah, sound would be good. Okay, it looks like the sound isn't going to work. But the patient, this is the patient before surgery, as I showed you in the segment before. And then in a few minutes here you'll see, this is him 3 years later after the surgery, and he has improvement of his blepharospasm, his oromandibular dystonia is better, his cervical dystonia is better. But he was complaining of feeling slow. It was subtle. His wife thought he was depressed because he wasn't really smiling as much and just seemed to kind of be not wanting to do as much. And he had some slowness of movement of his fingers when we asked him to open and close his hand as fast as he possibly could. There's also some decreased amplitude in the movements of his fingers. Not dramatic. He can still move his hand, but subtle changes. He also thought his walking was slow, and we did too. When he turned, he had to take multiple steps. Not quite as natural of a gait. He also complained of difficulties with kind of moving quickly. If he needed to get up to get the phone, he wasn't as fast. And walking backwards was a little more difficult for him. So we started to adjust the DBS settings. We found that when we lowered the frequency, one of the parameters you can adjust, that his speed of movement improved almost immediately. And his finger tapping and opening and closing hands was a little bit better. And also his walking is more natural. Now he's got a better arm swing. He can turn easily. And you'll see him jogging better. So this all happened in a matter of about 5 minutes just from changing the stimulator settings. But what happened, as I just alluded to earlier, is that his dystonia started to return. So you'll start seeing his head is pulling down more, and he's getting the dystonic symptoms back. Okay. So we proposed to do a pilot study looking at treating these same types of patients by stimulating in the subthalamic nucleus, this nucleus that's more commonly used in Parkinson's disease. And there was some preliminary data, case reports out there that this might be a potentially good target in patients with dystonia. And our hypothesis was that it would provide similar efficacy, but without these unwanted motor effects from GPI. And that it also might be better in the long term. It might reduce battery changes. The nucleus itself is a little smaller, and so it could require less battery adjustments and current drain on the system. And so I'm happy to say that this foundation actually supported this study, and also was partially supported by one of my patients, was a private donor. And I just want to thank you all so much for your support for this work, which was not going to be possible without some additional funding. All right, so today we have 9 patients who have enrolled in this study, and so far there's no major safety issues. We've had no problems with hemorrhage, which is one of the major side effects you worry about with this type of procedure. We've had no major infections, the other major risk factor, or the other major side effect you worry about with this procedure. And we haven't had any of the stimulation-induced bradykinetic effects. That being said, we've had a new type of stimulation-induced effect, which is sort of the opposite. So now patients, after surgery, when we turn on the DBS, seem to be developing some hyperkinetic movement disorders. They develop choreiform dyskinetic movements that look very similar to what patients who have advanced Parkinson's disease look like. So this has been a new challenge to try to now eliminate this side effect. And I'm happy to say that we so far have been able to successfully do that in all of 9 patients. But it has been an interesting journey, and the patients have been wonderful to hang in there and keep coming back to the clinic and have adjustments. And now we have, I think, a better idea of what are appropriate ways to set the stimulator to start with to avoid this. And I have a little bit of preliminary data for you on the first 8 patients. We're still waiting for some longer-term follow-up on these patients. But the first 8 patients do seem to be improved on using this Burke-von-Marsden movement score. There's about a 50% improvement, not quite reaching statistical significance, but we'll look at the individual components here and see if we can find out what aspects of their dystonia may be improved. My impression is that most aspects are. Their eyes, there are 2 patients that have prominent blepharospasm. Both of them have had some improvement in their blepharospasm. Most of the patients have had mostly cervical dystonia. And they've had a little bit improvement on their disability score, not quite statistically significant, but pretty dramatic improvement on their cervical dystonia outcome measure. So this is an example of one of our patients. a little bit younger patient, actually, than you might normally see with cervical dystonia, but very disabled by his condition. His speech also was affected. And I'm happy to say after his surgery, he has no more cervical dystonia. He's able to go back to work. He has no neck pain any longer, but his speech is still somewhat affected. So it didn't improve his speech as much as it's helped his cervical dystonia. Oh. Okay, well, there's only, I think, 1 or 2 more slides. The next, I was just going to show one more patient's video, and if we can get that up in a minute, that'd be great. I'm not happy with the Mac today. And so I was just going to finish up really by concluding that, generalized dystonia is now pretty well established as the use of DBS in those patients is pretty clear. As long as these patients have idiopathic generalized dystonia and have failed other other treatment options, this is definitely a therapy that they should be considering, they should be referred for, and can have remarkable life-changing outcomes. For patients with focal dystonia, cervical dystonia, as well as patients with blepharospasm or oral mandibular dystonia, I think we still have a lot of work to do in this area, but there is some evidence now to suggest that it can be beneficial, and we need to now sort out what kind of side effects these patients might be having as well, now that we're affecting the way the motor circuits are functioning. Oh, good. One more video here, I guess. This is just another patient with cervical dystonia. Again, on the left, her before video, as well as her, I think that's her 3-month post-op visit video. Really having trouble looking to the right here, but after surgery has much better range of motion. She was on high doses of narcotics before surgery, which she's been able to completely get off of now and is still working. So, another happy customer. Okay. I'm afraid to touch this. It's going to crash. So as I was saying, with focal dystonia, we're still trying to sort this out, but I think there's some promising results that are motivating me to continue to look into this and to try to find the best ways to stimulate the brain, what area might be the best to stimulate in the brain, and what kind of patients might be the best to benefit from this type of therapy. So that's really what I wanted to share with you. So.